is an associate professor and senior biostatistician in the Department of Oncology and Health Research Methods, Evidence and Impact at McMaster University. He is the faculty biostatistician with the Ontario Clinical Oncology Group, an academic clinical trial coordinating and methods unit, and scientist at the Scarpman Cancer Research Institute. He's the director of the CIHR-funded Canadian Network for Statistical Training in Trials, or CanStat, a pan-Canadian platform to train and mentor biostatisticians in clinical trials. His research interests are in the design and conduct and analysis of RCTs, and he's been involved in many of these as the lead biostatistician in large multi-center trials in various areas. And he was previously an associate editor for Pilot and Feasibility Studies journal, and mentors students in clinical trials methodology and applied biostatistics. And we're very lucky to have him here in Cape Town with us. So I'll hand over to you, Samir.
Thank you, Tanya, and thank you for having me. And just going to share my screen. I believe you can see that. Yeah, thank you, Tanya, for the introduction and having me. And today we'll be talking about pilot trials. And the outline of my talk is generally an overview of pilot trials. What is a pilot trial? What are the current practices? Some of the reasonings for doing these studies. The differences between a pilot and a proof of concept study. The sample size requirements for a pilot study. How does one evaluate success in a pilot trial? Some of the challenges, some of the common misconceptions, and then we'll just go over some frequently asked questions about these studies. So first, some dictionary definitions. From the Dictionary of Epidemiology, a pilot study is a small-scale test of the methods and procedures to be used on a larger scale if the pilot study demonstrates that the methods and procedures can work. From the Medical Statistics book, it's a small-scale investigation designed to test the feasibility of methods and procedures for later use on a larger scale, or to search for possible effects and associations that may be worth following up on a subsequently larger study. Some more definitions that I've come across over the years. This is from Ohio State, and it's a smaller version of a study that is carried out before the actual investigation is done. Researchers use information gathered to refine or modify a research methodology for a study and to develop large-scale studies. From Eskimo is to test basic protocols and design to be used in a research study. And then from VNet 5, a small study carried out before a larger scale study to try out a procedure or to test a principle. So previously there were multiple terms used without clear distinction: pilot work, pilot study, feasibility trial, pilot trial. Our colleagues in the UK came up with the framework, and the framework states that feasibility is an umbrella term, and a feasibility study asks whether something can be done, should we proceed with it, and if so, how. A pilot study asks the same question, but also has a specific design feature. So for example, if you're looking to do a large randomized trial, one may do a small randomized pilot study using similar specific designs. So pilot studies are a subset of feasibility studies, and randomized pilot studies are a subset of studies. So this is the conceptual framework here from the colleagues in the UK, and you have your main trial in the center, and then around it you may have a number of feasibility studies. One of them could be a non-randomized pilot study. You could have a pilot randomized study mimicking the main trial, and then you can have other feasibility studies to see whether the main trial can be conducted. So all the feasibility aspects, whether it's randomized, not randomized, or any other feasibility aspects, just focus around getting information of whether the main trial can be done and what needs to happen for that main trial to occur. So prior to 2010, as you can see, there was substantial variability in the practice of pilot studies and pilot trials. Terms were used interchangeably and inconsistently, and reporting was inconsistent. This was a review done by, again, researchers in the UK, where they surveyed 7 journals. They searched for the terms pilot or feasibility in the abstract, and they found 90 unique studies. 4 of the 90 specifically stated that the pilot was in preparation for a bigger trial. They then contacted the editors of the 7 journals. 4 out of 7 indicated that there was no publication policy on pilot studies, and 1 out of 7 indicated the journal did not publish pilot studies. This was repeated by Lancaster in 2007-2008. They found about 54 studies, and they contacted the editors at that point, and still 4 out of 7 indicated that there was no publication policy. So at this time, editors were not sure what to do about pilot studies, whether to publish them, not publish them, what was the reporting criteria, what were the methodology criteria before accepting for publication. The journal Circulation did publish 41 pilot trials since 2004, but the editors requested that the term pilot be added to acknowledge the small size and lack of generalizability in these studies. So really that goes to show that at that point in time, without the consistent methodology and reporting guidelines, editors were just wanted to make people aware that it was small and may lack generalizability. But that goes to know that that's not the objective of a pilot trial, as I'll show you, and therefore this was just being cautious. And then in 2010, Lahana Tabane, whom many of you may know, was my PhD supervisor, now colleague at McMaster, along with others, published a commentary in the BMC, one of the BMC journals, on how to do pilot studies, what they are, and why we conduct them. And that sort of changed things thereafter. So why do we conduct a pilot or feasibility study? Some argue, and there's some evidence for this, that lack or inadequate assessment of feasibility is one of the major reasons why large trials fail. And the biggest one of that is poor accrual. So we go into a large study, it requires a lot of resources to start up and get going, and then somewhere during the trial, we realize that, oh my God, we are not going to be able to complete this trial. We have poor recruitment, maybe some other issues, and the trial is terminated. This is a waste of resources because, as you know, it takes a lot of effort and a lot of resources to get a large trial going. And therefore, if you were to stop it halfway due to some feasibility issues, then one can argue that is a waste of resources. Some others also argue that it's unethical if you have not assessed the feasibility of completing a larger trial. And there's good data to show that majority of the trials stop prematurely because of poor accrual. So the objectives of feasibility could be multitude: clinically, procedurally, operationally, and methodologically. So one would want to know, is it feasible clinically to randomize patients, for example, in a critical care setting? Similarly, in a critical care or acute or trauma setting, procedurally, can we randomize and give the procedure as we intend? Can we operationalize this trial? Can we randomize, get the intervention in, collect the outcomes in a seamless manner, and then with trial methodology in terms of randomization or whether it's superiority or cluster, are we actually going to be able to achieve the goals we intend to do? So here are some examples of trials that pilot studies, and I'll give you their feasibility outcomes, and you'll see a lot of them contain recruitment, but each trial has its own unique feasibility issue that needs to be addressed. So this is a behavioral intervention trial for patients with depression. This was by one of my colleagues, Zainab Saman. And here the feasibility outcomes were recruitment, retention. Can we keep the patients in the study till the end of the study? What was the completeness of data? Was the intervention appropriate? Was there, did the patients appreciate? Did they take in the intervention? And what were the resources to conduct the main study? So if you do a pilot study, in some cases, you can get a sense of what it's going to cost to undertake the large study. This is a prevention of severe pneumonia study in critical care. Recruitment rates, again, were one of the feasibility outcomes. A high protocol adherence was one of the requirements, minimal contamination, and we wanted a small ventilator-associated pneumonia rate. This is a knowledge intervention of long-term care of vitamin D and osteoporosis. And here again, recruitment, retention, participation, completeness of data. Some similar themes across these examples. This was a cluster pilot study, and they were testing adherence to a risk assessment model and whether the risk assessment model can enhance decision for thrombophilaxis. And here they wanted to assess whether the risk assessment model was being completed and patients were being treated according to the risk assessment model. This is a study that I was involved in, and this is a nutritional supplement study in patient undergoing gastrointestinal cancer. Our feasibility outcomes here were whether we could recruit and whether we could randomize. As nutritional studies are difficult to randomize to. As you had to take a supplement, we wanted to know the compliance of taking supplements. If this was very low, then a larger trial would not be feasible. We wanted to know what the adherence was to follow-up visits, post-surgery, and if the post-operative complication rates. And this study, and in this trial, when we first started this trial, we were giving supplements 4 weeks prior to surgery, and we found that this was a barrier to recruitment and compliance. And so midway through the trial, we switched it to 2 weeks, but unfortunately did not see an improvement in compliance or recruitment. So you'll see here that every trial has its sort of unique feasibility issues that need to be addressed prior to undertaking large trials, but there are consistent things that many pilot trials assess, and those can be recruitment, compliance, and adherence. I did want to touch on this, and there is some confusion about this, of pilot versus proof of concept studies. A proof of concept study is to determine whether, in this case, a drug or some intervention is biologically active or inactive. It's usually based on surrogate endpoints as markers, and maybe could be tested in early stage designs like phase 1 and phase 2. Now, proof of concept is not necessarily proof of feasibility. If something has a biologically active mechanism, that does not mean we can randomize patients to take it and patients will be compliant to it. Here is an example of a proof of concept study for a mobile application. Again, they showed that they can collect reliable information on oral health through this app. However, again, if you were to want to test this in a large randomized trial, then one would have to do a pilot or feasibility study prior to taking that large randomized trial. The next issue around pilot studies, and this is very important, is the sample size justification. There's a lot of papers around sample size justification for pilot studies. Here are two papers by Stephen Julius at Sheffield. One states that the use of the confidence interval around a precision around an estimate of a quantity of interest. So if you're interested in a compliance rate of, say, 80% or 0.8, and you want to tolerate that, maybe a margin of error of 0.1, so for 0.7 to 0.9, you would calculate a sample size based on the number of patients required so that your 95% confidence interval is between 0.7 and 0.9, giving a margin of error of 0.1. And then based on some simulations, he said, oh, you'd require 12 per group for rule of thumb. And then others in the UK have said, oh, you need 50 per group, 30 per group, and then this is a nice paper by Kim Cooks in 2013, sort of summarizing the existing approaches. And you'll see here that there are many approaches to sample size justification for pilot studies, with it ranging from 50% of the total sample size of the main trial to about 10 or 15 or 12 per group. But you'll notice here that a lot of these are based on estimation of variance or standard deviation of some measure relating to the outcome, not really assessing feasibility in terms of what I've described in the examples before. These are estimates of variance that one would like to obtain for sample size justification in a larger study. Then similarly, another simulation study was done, and by individuals in the UK again, and they said it's 35 per group for continuous outcomes and 60 for binary. And again, this is to estimate either control event rates or variation. But the bottom line is there are multiple approaches to sample size determination, and justification is required. Generally, my preferred approach is the confidence interval approach around one of the feasibility outcomes or around more than one feasibility outcome. And now the criteria for determining success of feasibility. It is wise to include criteria for feasibility. What is feasibility? How will you assess whether the larger trial will be feasible or not based on your current pilot study? These criteria should be pre-specified in the protocol, and my advice would be to be flexible in determining the criteria. Okay, so here is the example of the risk assessment model for venous thrombophlebitis cluster randomized trial. And the objective here was to determine adherence to the risk assessment model. And they defined definitely feasible if the risk assessment model is completed for 70 or greater of the eligible patients. Here is another example of a trial of rituximab versus placebo for immune thrombocytopenia. And here were their criteria for success, whether they recruited 60 patients in a year, administration of drug infusions of those 60 patients, at least 54 of them got them, completion of follow-up, at least 50 patients, and successful blinding of patients and staff. This is another prophylactic thromboembolism trial in critical care, and they had multiple criteria for feasibility. Study drug received within a certain time, patient received study drug in a blinded manner, 90% surviving post-ICU, and recruitment as well. So in 2019, Lawrence Gbagbo and others at McMaster did a meta-epidemiological study where they tried to assess whether feasibility criteria or progressing criteria to a larger trial were identified in publications for pilot studies. So they reviewed all the pilot studies between a certain time point, and they showed that only about 20% of them had reported progression criteria or feasibility assessment in that, which is quite low. You always want to try put these criteria ahead of time and then make unbiased assessments of whether the trial is feasible or not. In the same paper, they looked at some of the factors that sort of affected that the 0.2 proportion and year of publication, which makes sense because the methodology was not really developed, and then region also was sort of prognostic of that. In the examples I showed you, that some of those were very clear cut and not very flexible. So if you didn't meet that criteria, you would not continue to a larger trial. And what's been developed since then is the traffic light approach, where you develop criteria and break them down into categories. So if, for example, the adherence is very low, you may stop the study, not stop the study, but you may not continue to the larger study. If adherence is very high, you'd continue without modifications. And if adherence is, for example, somewhere in the middle, then you would continue, but you need to modify something so that you can get the adherence quite high. So this is a more flexible approach to feasibility criteria, and this is the one that is suggested so that you're not sort of tied by the black and white yes or no go criteria that I showed you in some of those previous examples. This lets you determine whether some modifications can be made to improve some of those feasibility outcomes. This was published last year, and these are recommendations for progression criteria of assessing feasibility. And the framework sort of goes through the whole process and suggests that these progression or feasibility criteria should be considered in the design of the study. One of the main things that's come out of this is that you do not want to consider each progression or each feasibility criteria in isolation. They should be sort of considered all together because they're all part of feasibility. And therefore, if few are feasible and few are not feasible, you need to make an assessment around it, whether you can improve the ones that have not met the feasibility criteria and modify the protocol. And therefore, it's a whole package deal on whether the whole trial is feasible. Obviously, when you're doing analysis, then you should present the data for all the outcomes of feasibility, and you should report all of them. And you'll see in your reporting that it's very important that you pre-specify these, and so that you're not looking at the data and making a decision. So what are some of the challenges with pilot studies? Most are not well designed. Obviously, this has been improving with the consort and more methodology and more papers on it. Many do not have clear feasibility outcomes, and we'll get to that. There's no clear rationale for doing a pilot study. There are no clear analytic plans, and this should primarily be descriptive, and I'll go through that a little bit. And then we don't have any criteria for judging feasibility. Many are not published or reported. They're considered small studies and not reported. And many use pilot studies to estimate treatment effects. And we know that treatment effects from pilot studies could be unrealistic and biased. And if not used cautiously, they can result in misleading sample size or power calculation for the main trial. So while, maybe it is not so incorrect to get variability estimates from pilot studies, although you should be cautious about this, the treatment effect should still be the minimally clinically important treatment effect that one requires for the large trial and should not be based on a small pilot randomized study looking at interventions, looking at feasibility outcomes, sorry. Common misconceptions, and I'll go through these. This is a small study that can be completed quickly and can be done by a student or intern. From my experience, these are not small studies. They cannot be completed quickly. They still require the startup of similar to a large trial. They require protocols, REB approvals, contracts, and so forth, completed follow-up, adequate data collection. And so these are not small, quick and dirty studies that can be completed. Another misconception is that you don't require funding. Again, as you can see, it's just like doing a big study, and therefore it requires resources for staff, for databases, for contracts, and so forth. Another misconception is that it's just a small study and I have funding for 10 patients, and so I'm going to do that. Again, this requires good methodology with appropriate sample size calculations, and therefore not a small study just based on the amount of funding. The next is, it is a small single center study because I don't have resources. For a large study, that's not what a pilot study is. Again, it requires full-blown methodology and conduct and coordination. Some of the things that I've had people come to my office are, oh, I did a similar study with X amount of patients and I got statistical significance, and so ours is double and double the size. Again, you have to justify your sample size and you have to coordinate this with good methodology. And some of the FAQs that I'll go through now, which I've heard, can I publish the results of a pilot study? Yes. This is a study on patients or participants, and therefore every attempt should be made to publish them. Why is it important? It's to provide information about feasibility, research to the research community. It saves resources, so somebody else doesn't have to really go through these efforts. And we have an ethical and scientific obligation to do so. Now, this is the biggest issue that I see with pilot studies, is that investigators do a pilot study and they want to compare statistically outcomes between the two groups. It is very, very critical that the focus of a pilot study is on feasibility and not statistical testing. You're assessing feasibility of methods, procedures, operations, and so forth in trial. The trial generally is not powered for statistical testing of clinical outcomes between randomized groups. Therefore, the biggest thing I've seen as an editor of the pilot and in reviewing these studies is that one says they're going to do a pilot study looking at feasibility outcomes, and then thereafter statistically compare the two groups on clinical or relevant clinical outcomes. As I said, the pilot study is not powered for this. It should be avoided at all costs. The pilot study's primary objective is testing feasibility, and therefore the way the results should be presented are descriptively based on feasibility. Some other important questions. Can I combine data from a pilot with the main study? Yes, you can, provided the same methodology, the same randomization and so forth is used. And again, that you have not analyzed the clinical or efficacy outcomes after the pilot trial is completed. So for example, You do a pilot study, you deem that it's feasible, you have collected the clinical outcomes that are important, but you have not analyzed them, and therefore you can continue that study and merge this data into a larger trial so that the patients in the pilot study can be part of the main study as well. But the critical thing is, has to follow the same methodology, and there is no analysis of the clinical outcomes after the pilot is done. Second one is, can I combine the results of a pilot with results, excuse me, of another study in our meta-analysis? Yes. However, generally you don't have treatment effect data, so it's likely not available. If you've done the pilot study correctly, again, you're not analyzing clinical outcomes, and therefore the treatment effects are not present. If that data is amalgamated into the main study and then clinical data available, yes, sure, you can use them for a meta-analysis. Can a pilot ever exist on its own? I certainly hope so. If the results of a trial show that it's not feasible to go to the main trial, or there's no funding for the main study, then yes, a pilot study can exist on its own and should be published and be presented so someone else doesn't have to go through that process. Can I apply for funding for a pilot? Absolutely. It is important to justify the need of piloting. The pilot is required, for example, before the main study can take place. And these are not small, quick and dirty studies that require resources and experience and expertise. And therefore, yes, funding should be sought for these studies. A couple other important issues. Yes, obviously you can randomize. It's always best if you're thinking about the large study that you try to pilot that same design in the feasibility study. So if you're doing a cluster randomized trial, it's beneficial that you pilot a cluster randomized trial. It's that shows that the design is feasible in that setting. I've talked about this before. Can I use a pilot to estimate sample size? And I mentioned that this is not the best idea. Consider getting patients involved, physicians involved in determining the minimally clinically important difference, but estimating treatment effects from pilot studies is unreliable. Can I use the results of a pilot study to treat my patients? This is not, again, a good idea because we're not assessing efficacy here. So pilot studies are not used for treatment decisions. And what can I do with a failed or bad pilot study? No study is a complete failure. If it's not feasibility, it's important for others and yourself to learn from it. And the last one is, should I register my pilot study? Yes, on ClinicalTrials.gov or any other registry. This is a full-blown trial in the sense that you are randomizing, there's patients involved, you're collecting data, and therefore it must be registered. After getting the sense that there is some uncertainty and variability in the framework and in reporting of these trials, the consort statement extension was published, and therefore now this gives clear guidance on what to publish and how to design a randomized pilot of feasibility studies. Again, Lahana and Julian Lancaster, the coordinator chiefs of pilot and feasibility studies, wrote an editorial on reporting of protocols. If you have a protocol for a randomized pilot or feasibility trials, it can also be published, and the pilot and feasibility studies journal will accept those, and it's important that you publish this as well. So in summary, pilot and feasibility studies are important designs, and they assess whether the larger, big, important, expensive trial can actually be conducted. So it's important to assess the feasibility of that before launching into it. The methodology should be rigorous, just like the main trial, because you want to get the best assessment of feasibility that you can. Again, these are not small underpowered studies where you don't have a lot of funding or just have a few number of patients and then intend on comparing statistically clinical outcomes between the two groups. The objectives here should be feasibility and not treatment effect. Avoid using statistical testing between the two treatment groups here and just focus on feasibility. And include feasibility criteria in your protocol and publications so that you don't make decisions based after looking at the data. And publish protocols as well as results of the paper. Thank you.
Thank you so much, Samir. That was a really excellent, clear presentation on a very, very important topic. Now I'd like to open it up to the audience for comments or questions. Okay, the first person, Zemsi, go ahead.
Okay, yes. Hello, you get me?
Yeah.
Okay, thank you for this nice presentation. It was really insightful and helping understanding and to get rid of some misconceptions. So I just want to make sure that I properly got what the message like. So a pilot study actually, it's we talk about pilot study when it's satellite of a main study, and not when it's not about the size and also the scale of the implementation of the study, but it should be a satellite of a main trial that has been approved. And the second question is to know if an investigator has a main trial that is being conducted, and then he has another idea that pops in a study, like maybe a clinical trial where they are comparing the efficacy of two drugs. Then he noticed that in one of the drugs, maybe there is a side effect, and he wants to, do another research on that. And he used that new idea as a pilot study. And how can that be related to the fact that it should be feasible study? Thank you.
Zemsi, can you, I missed the first part of the question. Do you mind repeating that?
Okay. So I was saying if an investigator has a study where he's comparing the efficacy of two drugs, that is his main study. And
Yeah.
after he noticed there is a side effect of one of those drugs, and he wants to study that, but he has to do some other lab exams that were not specified in the first protocol. Can he use that as a pilot study, and how can it be related to the fact that you said it should be a feasible study?
Yeah, so I think there's two different things if I understand correctly. One is if there is something else going on in the lab, that is not an assessment of feasibility. That's more like if there is some biological effect of that, the hypothesis that individual investigator. The pilot study looks at whether the larger trial can be done. And that's a bit different from whether they think the drug is effective. They obviously think the drug is effective, but it doesn't assess that. And it's like, if we are going to test whether the drug is effective, we need these criteria to be met for the full trial to go on. So if there is some, lab basic science indication that that this drug may work in some indication or not, that does not necessarily mean that the trial will be feasible. So there has to be an assessment of feasibility to show that you can do them full major trial.
Thanks, Samir. Zemsi, does that answer your question? You were talking about observing side effects in a trial. I'm not sure where that fits in
Yes.
with the pilot trial.
Yes. So actually, if you like notice a new side effect on one of your trial and you want to like look more into that, which type of study then will you carry? Since you can't do new labs investigation that were not approved in your protocol.
Right. So if you see more side effects than you anticipate in your larger trial, right?
Mhm.
Yeah, then I think you, before even getting into a pilot study, you may have to do some early stage design to look at the dosing and the side effects prior to moving on to even a pilot study. So generally here in the pilot studies, we know the safety profile of the drug, we understand its things, and so you can assess safety in this trial design. It's not like you cannot, but generally it is not the goal. If you're looking at safety issues, generally a more early stage design is a better approach, especially if you're seeing higher side effects than what you expect. It may be, you may need to do some PKD, PK studies for that.
Okay, thank you.
We have a question in the chat from Priscilla Springer. How would you choose a journal to publish a feasibility trial, for example, an observational cohort study involving childhood cognitive and emotional development?
So I know for a fact that the pilot and feasibility studies will publish protocols and pilot studies of this setting. Obviously, not all journals have a publication policy or will publish pilot trials, and so if there's something in that specific area, you'll have to look at that journal for whether they're accepting pilot studies. A lot of journals are these days, but the pilot and feasibility studies will definitely publish the what you're referring to, as well as the protocol. I know a lot of disease-specific and condition-specific journals will not publish protocols, but they will publish the final trial results. But pilot and feasibility studies will do both.
Thanks, Samir. Scylla, does that answer your question? Okay. Is there anybody else who has a question or comment for Samir? Perhaps while we're waiting, I just wanted to ask, you mentioned that the analysis of the feasibility studies is through the use of descriptive statistics and confidence intervals around the feasibility outcomes. How would one interpret the confidence intervals if they're likely to be very wide because the sample sizes are small? Would you give clinical cutoffs beforehand to try and interpret what those confidence intervals are telling you, or how do you use them?
Yeah, so generally we do some, in the progression criteria, we will give some guidance, and usually people do it around the point estimate. Although they do present the confidence intervals, but it's not like, as you said, you require a large number of samples to get a narrow confidence interval. So if you're going to state that the lower bound of your confidence interval over adherence has to be greater than 70, you would require it to be close to 90 with a wide confidence interval. It's a good point. People usually do it based on the point estimate, and then the confidence interval just gives them a sense of the uncertainty around that. Agreed, it's not the best way of doing it.
Okay, thanks very much. Any other questions or comments? We have another one in the chat from Marcel. Can I apply for ethics approval for a feasibility study and the large trial simultaneously?
If I was sitting on the ethics committee, I would say you have to show me that the feasibility study is successful before I grant you ethics approval for the large study.
Yeah, I think that's probably how Stellenbosch University's HREC would work as well. If there's a reason for doing a feasibility study, you would want to delay that main study to see the results first. Any other questions or comments? Okay, I don't think there are any other questions or comments. Thanks once again, Samir, for a really enlightening, wonderful presentation. So important for us to know the distinction between these different types of studies and not just use them as baby studies because we don't get the sample size. And I'd like to thank everybody for attending. It's Lincoln's asking if we can access this again. Yes, we are recording it. So we will let you know where we put the recording so you can access it again. Thank you to everyone for attending our global health seminars, and thanks again to Samir for this wonderful presentation.
Thank you, Tanya.